Okay. So what we're going to talk about, I'm going to give you an overview of the auditory system. There is a lot of material within this particular PowerPoint, and most of it is really relevant. But what I want to do is really get you just focused on the things that are going to be covered on the final exam. And so the first I want you to focus on would be slide 5. Okay, so slide 5, what I want you to focus on is understanding the structure of the auditory system. What are the components of the auditory system? All right, and so this is in slide 6, be able to differentiate between the vestibular system, auditory system. The cochlea is associated with the auditory system. The semicircular canals shown here, the anterior and lateral semicircular canal, the ampulle, the utricle, and saccule. These are associated with the vestibular system. So know how to differentiate between vestibular system and auditory system. Okay, on 7, know about the ossicle bones. That is the malleus, incus, and stapes. These are the bones that are going to transmit sound into eventually activating neuroactivation of the hair cells. Okay, so just be familiar with these 3 different bones. Okay, next, know just a little bit about the physiology. And so the areas I want you to focus on in terms of the physiology is the perilymph. This is going to be the solution that's surrounding these hair cells. And so, and the other is the endolymph. Endolymph is like the intracellular fluid, and the perilymph is the extracellular fluid. Okay. With the perilymph, there is the thing that I want you to remember is that with the perilymph, there's just low potassium concentration in the perilymph. In the endolymph, there is high potassium concentration in the endolymph. The importance of that is this is what's going to cause the activation, the generation of an action potential. So inflow of potassium causes a depolarization of these hair cells. And this is really rare. This is really kind of associated with the vestibular system and the auditory system. Okay, because remember with normal neuronal activation, it's that influx of sodium that's causing depolarization. Here, it's potassium. Okay, on slide 15 then, in terms of the neurophysiology, in terms of how sound is being transduced to a neural activation and generation of action potential it's due to the sound causing a mechanical displacement of these specialized cells called hair cells. And these hair cells are located in the basilar membrane, and they will move based upon the sound. And so this is the movement is involving a shearing effect of the tutorial membrane. And what this is going to do is going to increase the permeability to potassium ions. So potassium ions are going to influx to create this graded or local potential from these hair cells. And this, what it's going to do is that this is going to activate these voltage-gated calcium channels, and then calcium is going to come in due to that depolarization. And that's going to be involved in trying to release from these specialized cells of the neurotransmitter. And the neurotransmitter that's going to be released from these cochlear hair cells is glutamate. And glutamate is going to be released, and it's going to bind to a glutamate receptor on these cochlear nerve fibers with these afferent fibers. And this is what's going to activate your action potential on these cochlear nerve fiber afferents. Okay, and then this action potential is going to project to the brain stem, and it's via this vestibular-cochlear nerve fiber. Okay, so we're going to turn to slide number 23. Again, what's happening is that this gating of this potassium channel. Okay, this is a mechanical channel. Unstimulated, the spring relaxes in this diagram, and the potassium channel is closed. The stereocilia shown here, that's on the specialized hair cell, will bend towards the largest stereocilia shown here. And what this is going to do is going to open the potassium channel. And potassium channels are going to flow from a high concentration to a low concentration, and they're going to enter inside the cell. And by entering inside the cell, that's going to cause your depolarization. Okay, and so here this shows right here. And so if the hair cells, the cilia, flow in the opposite direction of the largest stereocilia, that causes hyperpolarization. If the stereocilia flows in the direction of the stereocilia, the largest stereocilia right here, this is going to activate these potassium channels. Potassium will flow in, causes depolarization. This is going to activate a voltage-gated calcium channel. This is going to mobilize release of neurotransmitters within these specialized hair cells. Glutamate, it's a neurotransmitter, is going to bind to glutamate receptors on this cochlear afferent, and you're going to get propagation of the action potential. Okay? And so that's kind of a simplistic explanation of how you get activation. All right. And so next I want you to go to slide number 27. And so what I want you to be familiar here with slide 27 is the central auditory pathway. You know, what are the components of this central auditory pathway? And so the cochlear complex, the auditory cortex, this involves the cochlear complex, which is superior olivary nucleus. You got fiber tracts, the lateral lemniscus, so that's an auditory fiber tract. It's going to project where? It's going to project to the inferior colliculus. From the inferior colliculus, you're going to get a projection to the medial geniculate nucleus. This is part of the thalamus, and then it's going to be relayed from the medial geniculate nucleus to the primary and secondary auditory cortices in the temporal lobe. And so I want you to be familiar with the components. And then what we're going to do is we're going to go ahead and we're going to expand on this. So I want you to turn to slide number 30. Okay, and so let's expand just a little bit. So the cochlear nuclear complex is, I want you to understand that the fibers of the vestibular-cochlear nerve enter the brain stem at the pons medullary junction, and they're going to terminate in the cochlear nuclear complex. Afferent from IPSI, cochlear hair cells, or synapsing. And then where is the projection going? And so cochlear nuclear complex is then going to do what? They're going to project to IPSI and contralateral ascending auditory pathways. And so you're going to get some crossing. And so the cross is going to project to the superior olivary nucleus. And this is located in the dorsal pons. The ipsilateral projection coming from the cochlear nucleus is going to synapse onto the IPSI superior olivary nucleus. So you're getting both a crossing that's going to synapse to the contralateral superior olivary nucleus, and you're getting an IPSI. So auditory is going to be bilateral at this point, okay, in terms of the information. And so where does the superior olivary nucleus project to? Well, they're going to project ultimately into the thalamus, okay? And so I just want you to focus on the projection with this particular slide. And so here, this kind of diagrams what I just talked about. So you have your afferents coming in here. Here's your olivary, your cochlear complex. There's a dorsal, there's a ventral olivary complex. Some of these are going to cross over to the superior olivary nucleus, others going to septs within the ipsilateral olivary complex. Okay, and then from there they're going to give rise to this lateral lemniscus, and where the lateral lemniscus is going to project initially is going to be the inferior colliculus, shown here. Okay, and then from the inferior colliculus it's going to project to the medial geniculate, abbreviated MGN, right here, and then from the medial geniculus right here is going to project into the auditory cortex. Okay, so next I want you to turn to slide number 38. Okay, and so again, let's look at the pathways, auditory reflex. And so your first pathway is a projection to the inferior to superior colliculus. So you're getting some projection from the inferior colliculus to the superior colliculus. Okay, and collectively the inferior and superior colliculus is called the tectum. And what that's going to do is that's involved in sort of rotating individual's head towards this auditory stimulation. And so you're having control of not only muscles to the head, but also you're having control of extraocular muscles. And so this is your reflex here. And so your secondary pathway that's going to play a role in terms of controlling your extraocular movement is your superior olivary nucleus is going to project fibers via this longitudinal fasciculus that are going to connect to the oculomotor nerve, trochlear nerve, and the abducens, all involved in terms of regulating these extraocular muscles. Okay, and that medial longitudinal fasciculus is the fiber tracks that are connecting the abducens, the trochlear, and the ocular motor. Okay. The third projection is going to be to the vestibular nuclear complex in the cerebellum. And so this basically is going to do is that as you're turning to auditory stimulation, you need to maintain balance. And so this is a way balance is maintained via the vestibular and the cerebellum. Okay, next I want you to turn to slide 41. Okay, now in terms of lesions, I want you to be familiar with basic types of damage to this auditory pathway. And so a unilateral central auditory pathway lesion, you're going to get mild bilateral loss of hearing. And again, because of the fact that you get this crossing over auditory information to the contralateral side. Okay. But if you do a bilateral auditory lesion, then what's going to happen is you're going to have profound loss of auditory discrimination and speech perception skills. So a bilateral lesion will do that. Okay. Next, I want you to turn to slide 47. And so here, I want you to be familiar with the types of damage depending on where the damage is occurring. Okay. For a conductive hearing loss, you're going to have damage to the middle ear. And so this is interruption of sound transmission that's occurring in the cochlea. And for sensory hearing loss, you have damage to the hair cells. This could be due to either a load noise or drug damage. And there's certain antibiotics will damage these hair cells. Or you could have damage to the auditory nerve. Okay, and so these are areas that I want you to be familiar with. In terms of central hearing loss, this is due to either some kind of tumor, some kind of lesion, due to some kind of impairment of blood flow, traumatic brain injury. And so stroke or TBI or tumor growth will affect central hearing loss. Next on slide 48, what I want you to mixed hearing loss, I want you to kind of review this for the exam in terms of mixed hearing loss, central auditory impairment, and clinical characteristics of hearing loss, and the types of deficits that will be associated with that. Lastly, I want you to correlate hearing loss in terms of with the lower brainstem. And so that what structures, what types of hearing loss modalities that you'll see associated, for example, with your superior olivary nucleus or damage to the little meniscus. In terms of upper brain structures, what kind of damage and symptoms that you'll see there too. And so these are the slides I want you to focus on that will be covered within your final exam.